How do you guys feel about that? It doesn't matter. No, I'm just kidding. Of course it does. We'll see if this is helpful. If it's not, let me know at the end. But so start off with neuro case, 57-year-old male. So I'm working downtown Baptist in say a largely underserved population. So I get a call from EMS. They're bringing in a 57-year-old male. He's found face down in a parking lot. Have we talked about this already? No, we did. You gotta stop me. I'll just wind up again. 57-year-old face down, not witness. They bring the guy in. On your left is how I want him. On the right is how I get him. So I meet EMS. They're wheeling him back. They didn't put him in one of my trauma rooms. They put him in like close to one of my trauma rooms, but not quite the trauma room. And then as I was meeting them, they were literally like throwing this guy on the bed. No shade on EMS. How many paramedics EMS here? No shade on y'all. And I got a quick dump from him, and he's like, "Hey doc, he's drunk." I'm like, all right, cool. What else? Like face down, ass up. Nobody knows, nobody saw it. I was like, that sounds like a song. But here are my vitals. So heart rate 120, BP is high, really high. Respir's high, temp high. Glucose bedside high. GCS 10. What do you guys want to do? Nothing? Oh, no, please. I don't want to touch this thing. What do y'all want to do? Anything? How about we'll get that guy looking like that guy and start over? Like, let's just hit reset. So let's put him on a board and collar him. Is that a good idea? Never a bad idea. We're in the ER, so you guys haven't had emergency medicine. So IV O2 monitor. What are we concerned about with those vitals? What are we not concerned about with those vitals? I love it when I'm down. So we just did a mock OSCE, and I had a headache case, and they were like, "Dude, this lady's 140. Her blood pressure is 140 systolic. Like, she's gonna die in a second." And I'm like, "That's just not." So I bet you like half of you guys are 140 frustrated right now. But anyways, is 220 over 150? And these numbers are out of my head, so it might have been 120. 150 seems a little high to me right now. I'm looking at it, but is 220 over 120? Is that high? Yeah. Yeah. What are we concerned about? Yeah, like bleeding? Like, yeah, like, so, I don't know, like she's compensating, something's going on, or he is compensating, rather, so. All right, so we put him in a collar. I tell the nurse we need to, or I ask the nurse, do not tell your nursing staff anything, I need this, right? So HR's nurse, like, I think we ought to move this guy to a trauma room, right? And I forgot to mention my first glance, he's got a bone sticking out of his arm. Like, what happened here? Like, so trauma naked the guy, we got his clothes off, and I'm like, oh, that looks bad. Like, distractor, right? Don't fall for it. I don't really care about it that much. So, board and collar, IV O2 monitor, ASAP, airway breathing circulation, stable-ish. I mean, GCS 10, not awesome, suboptimal, but he's breathing, he's responsive. Tubo now, later. Think about it. Get ready. I'm ready. I'm always ready, man. He is protecting his own airway. He stinks of alcohol. He's filthy, like before we remove all his clothes, and then he's filthy under that. So, altered mental status, neuro exam, trash, compromised, right? We're going to talk about neuro exams a bunch in this class. Just a plug, scan all your intoxicated patients with suspected head trauma. Why? Why else? Nobody's ever been drunk in here? Are you reliable? Do you make good decisions?
Always.
So if you come in and you have a big gash on your forehead or hematoma, but you're wasted, and you're like, I feel fine, Doc, you're going to be like, all right, cool, man. You feel fine, you're good? Oh. Absolutely. Unreliable, completely unreliable. He's intoxicated. So we know he's going to get a head scan regardless. But I take a look at his chart, multiple admissions for DKA, meth abuse, alcohol abuse. He's ESRD, dialysis Monday, Wednesday, Friday, so his kidneys don't work. He usually leaves AMA. So I got a little bit of a biopsy on him, so I'm like, okay, what do we got here, right? Rainbow Labs, what do you guys think? Try to put it in a better light, I guess. Yeah, last, I don't know. Yeah, last dialysis, probably last admission, which was 2 weeks ago. I don't know. So we're expecting K to be out, acidotic, all that good stuff. So, anybody want a CBC? Anybody want a CMP? Anybody want a trope? Yeah, so that was the whole thought process. So just like SpongeBob, when we say Rainbow Labs, just what I want you guys to start doing perfectly adequate. Like people here will just be like, no, you can't get Rainbow Labs unless you tell me what they are. I'm gonna tell you guys the truth behind it. So with this patient, if I'm worried about like sepsis, which I am, I'm worried about stroke, which I am, I'm worried about DKA, which I am, right? There's gonna be drop downs where I just click bundle and all this stuff comes up. So like it's not as scary as we make you think it is, but I want you to think about it as a student. Why do I want a CBC? I'm not going to give you your electrolytes, it's your CMP. Were we worried about bleeding earlier? Is that going to give me an H&H? Is that going to give me a leukocyte count, leukocytosis, leukopenia? Could he have HIV and be immunocompromised? I don't know much about this yet. So just when you're going through this, especially my ClinCore folks, when you guys are in ClinCore and you're like, let's go, we're in trauma 2, I want it all. Just be able to articulate why. I want to explore possible infection. I want to check his H&H for anemia, right? It's not going to give you the answer. It doesn't pop up and it's like, meningitis. You're like, oh my God, right? It's just a piece of the puzzle leading you to something else. CMP electrolytes, absolutely. Troponin, why? It pushes a crappy story, and it's on the drop down too, right? And I'll also tell you that his stroke's going to be high because of demand, because his kidneys don't work. So, anyways, you guys will learn that stuff later. But UA, yes or no? You can't. Oh, he's obtunded. How do we get PV from him? Not me. Someone's going in to get it, right? Sir, pee in this cup. I can't, right? In and out, get some urine. It's pretty easy. So, drug screen, or just assume what?
He's on meth.
He's on them all, right? Yeah. So get a drug screen that can help you. A VBG is going to give you some of your oxygen saturation a little bit better. ABG, VBG, I don't care. It's also going to give you a lactate, or you'll find out if he has a lactic acidosis, which can also tell you end organ damage or breakdown as well. Plus or minus mag or phosphate, because we're going down that DKA rabbit hole. Chest, PA lat. You guys want a chest x-ray on this guy?
Yep.
So you guys will learn, if you haven't done ATLS yet, chest and pelvis for everybody. Especially those folks that can't talk to you at a minimum, right? And then CT, well, we're going to do a blood culture. We'll think about an LP maybe later on in this. What are we going to CT on this guy? Yeah. I hate to say it. He's getting a pan scan, right? So what is a pan scan? Yeah, head, spine, chest, abdomen, pelvis, right? Why? Why are we being so aggressive with this guy? I have no idea what's going on. I don't want to miss something, right? So don't be afraid to do that, right? So again, but like I challenged you earlier, why do you want the CT in his head? Well, his GCS is tagged, and he's obtunded, and he's drunk, right? Why do you want a CT of his belly? He could be bleeding internally. I don't know, right? His exam was just all over the place because he was like that first picture, curled up in a ball. Okay. What else? Anything else? So what's this guy's deal? Life has been hard. He was an iPad bailout.
God.
Too soon? Come on, man. So like I said, trauma, sepsis, stroke alert. Pick your 1, 2, or 3. I decided to go for the hat trick, right? His CBC 20K north, left shift, so he's got an infection. His lactate was 5.0. His K was 6.7. What do we got to do with that? We probably got to shift it extracellular, intercellular, right? So that's something like we'll talk about. Like, do I care about all this stuff? Do I care that his CBC is 20K? A little bit. Is it going to kill him in the next 5 minutes? Hopefully not. But I definitely want to action something, right? And that'll be your sepsis bundle. I'm probably just clicking, thanks, no, I don't know. Like you guys are like in fog. You're like, that's not what she told us at all, right? Drug the bug. I don't know what's going on with this guy. His trope was bumped, right? That's probably demand because his kidneys are trash. His alcohol was 300, meth, cocaine, THC. He was probably on some other stuff. So he's a poorly controlled diabetic, alcoholic, drug addict, ESRD patient that needs dialysis in DKA with an open fracture and NEURO, ding, 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 right? So just a little side note before we get to a CT scan. When I talk about dropping this stuff or like click sepsis bundle, right? So this stuff is going to populate for you. You just have to override or choose if you want to do that. It'll say like sepsis bundle, click, and then it's going to have all these labs. You have to go in as a provider and unclick the ones you don't want. You get to the bottom and it's like, do you want fluid replenishment? I hold off on this guy a little bit because I don't know what the hell's going on with him. His pressure's through the roof. Do I really want to drown him? No, his kidneys are trash. Do I really want to drown him? I'm going to let the ICU worry about that. But for the meantime, I decline fluids. Did I go with antibiotics?
Oh, yeah.
It says sepsis, source of infection. What do you think I checked? Unknown. I have no idea. It could be anything, right? So unknown, vanxosin, Tylenol, shift his potassium, so calcium glucate, insulin, and fluids. RSI, we took his airway because he started to go down a little bit. So we're like, whatever, let's not mess with it. If you're thinking about it, probably just do it. That was one of those cases where we're early, and I'm like, I don't know, man, he's protecting it. I'm not, yeah, I don't know, man. And I came back, and they're like, his GCS is now 7, and he's posturing, and I'm like, oh, sweet. Probably should have tubed them earlier, but just some drugs you guys can, etomidate, rock, whatever you want or whatever you're comfortable with, and you guys get through emergency medicine. So what really can I do for this guy?
Set him to the ICU.
Elevate his head, control his blood pressure. That should be priority 1 for me. And I'll tell you what, I already know he has a stroke because I already got the results. Yep, we're going to consult, absolutely. But radiology called me and said, hey man, what's the deal with this guy? Because I don't know, you tell me. He's like, he's got a brain bleed. I'm like, all right, sweet, that makes a lot of sense. So you go back in there, and then I start focusing. I hyper-focus on his blood pressure. Because if you guys remember, it was like 220 over 120, and he has a hemorrhagic stroke. Is that good? So he's got an open vessel popped in his head, and his pressure's through the roof. What is that doing to his parenchymal tissue? It's killing, right? It's killing. Antiemetics, yep. Zofran, why don't I want this guy to puke? What does that do to your ICP? Yep, he's a drunk. He's got a head trauma. Is he going to want to throw up? Probably. So let's preload this. Paretics, he had a 101.5 fever, so I gave him some Alphamed. And then anti-seizure meds. You want to do an anti-seizure meds? If he has a high propensity to seize with bleeding into his brain? Yeah, absolutely. Do I split his arm? I do. Why? You guys are going to be awesome, and I felt like it. I was like, yeah, we should split that, because I had to call ortho, and what is ortho going to say? You guys seen the running joke. Like, hey, where's the fracture, right? I've got a guy that's trying to die 7 ways, but he's got a broken arm. Like, we should fix the fracture first. And I'm like, no, he's got way more problems than that. So just the drunk, don't fall for it. We consult. Who do we consult? Internist, hospitalist, neurosurgeon. Who else? Nephrology, he needs dialysis. Ortho.
Psych.
I did it, but not a bad guess. Not a bad guess at all. So. All right, here's the CT scan. I can only give you guys a couple slices. I wish I could go through it. So that's not good. That's not good. So if you guys forget from RADS, like that white stuff there, it shouldn't be there. That's blood. It's in his ventricle. Actually, it's coming out of his ventricle a little bit too. So,
Yeah.
What is he going to need? Anybody want to take a swing?
Put him in a hole.
Someone say drill a hole?
Yeah.
Yeah, not it. Right? So yeah, that was the first person at bedside was neurosurgery. So they're going to do a extraventricular drain or an EVD. I put this up there because they're super cool. I hope you guys get to see them. A lot of times, these are kind of the measurements where I'm not going to test you on this, but essentially they're going to drill a drain into that ventricle to evacuate some of that pressure in the blood. So, can you get 2 EVDs? Yeah. Right? That's a bad day for you. He didn't need 2, but he definitely needed 1. So. All right, what do you think? Fun?
That was fun.
Any questions?
All
All right, that's all I got for today. Go home, guys. Yeah. He was, I saw him again, too.
We survived.
Bro. I was just like, terrible. Don't strike me down. They're like cockroaches. Don't die. Don't die. But if you or I have any one of those, we're dead. Like, I break my forearm hard enough, I'm quitting. But I guess later on, like once the story came to and his alcohol came down and his DKA got fixed and his blood was evacuated, he was assaulted. Yeah, he was assaulted. Someone hit him in the head with a bat. So can he be the town drunk? Well, San Antonio, a town drunk. I don't think he was the one, right? But can you be a town drunk, meth addict, drug addict, and still have head trauma? Hell yeah, you guys know that. So don't listen to your, trust your instincts and go through the process. So if we didn't get him trauma naked, put him on a board and collar him, like I probably would have missed his arm. That's uncomfortable. But he died, right? No, but his bone was sticking out of his arm. That's bad form. So, all right, questions? I try to interject some of those, get you guys involved a little bit, and not kill you with PowerPoint, but there's no way around it. We're going to kill you with PowerPoint. So. All right, you guys know where I am, who I am. I want to introduce my replacement. Another masshole.
Yes.
Yeah. So Major McMahon, he's going to left seat, right seat with me this one, and then take over next semester. So if you guys see him, say hi, be nice to him, or else. All right. But he's also from Massachusetts, so he's a good guy automatically in my book. So. All right, this is obviously MP 620 Neuro. This is a 2-block test, or 2-block course with 2 tests. You guys already know that, right? Where's most of my stuff come from? The slides. Your 51 slide review.
Yeah.
Yeah, we'll do that. We'll hook you up with success. Don't worry, I got you. I got you 6. It says there, so the slide material comes from the books, right? So if I've had feedback before that, like, hey, we didn't go deep enough in this, or I really wanted some more. Highly encourage you to do that. I'm not here to slow you down. This is specifically going to be a neuro for your family medicine provider, okay? So I do tend to focus a little bit more on like headaches and strokes, right? Because I think I see those a little bit more, and I don't want you guys to miss strokes and be comfortable with it. But when we get to like Guillain-Barré or some of like, how many folks on active duty are going to have Parkinson's disease or Alzheimer's or ALS? Not a lot. If you find it, they're probably going to be med boarded. What do you think that's going to be on your PANS test? Yeah, it is. So that's why we're going to talk about it. So some of the folks are like, hey, I really want to talk more about MS because my family has it. I'm like, oh, sorry, bro. Like, yeah, look it up and let me know how you feel. But, source text, PANS blueprint, 7% of the exam. So is that a lot?
Yeah.
I don't know. It's not as much. I'm like, 7%, right? It's a number. It's quantifiable, but it's not as much as what?
Cardio.
Cards and poem, right? So those are your big hitters. But it's there. You're gonna get neuro questions. So, oh my good lord, you gotta let that out. You gotta let that out. You all right? Yeah. All right. God bless you. All right. Some of the things we'll talk about. You guys can read that. I'm not gonna read it to you. But like I said, headache. Did you guys? I heard Dr. Graham told me you guys are already well versed in meningitis. He said you can ask him anything you want on meningitis today. I feel like I'll ask you guys and you'll be like, what is that? We don't know. Right? Koenigs and Brzezinski, is that what you said? Oh man, that's good enough, right? Rigidity, fever, headache.
We're there.
Yeah, we're there, man. We're there. Should we talk about how to do an LP? Or just that they need an LP?
CT first. CT first. CT first, always.
Yeah, why? Oh my God, this is melting my heart. Why?
You don't want your brain to pop out.
Yes, yes. You guys are already crushing it, man. You're way better than other classes. I don't just say that. Their classes are just like, well, I don't know, because everybody gets a CT. I'm like, no. There's a reason, right? So we get that CT, just like my first case there. We get that CT non-con ASAP because that dude has a bleed in his head, right? That I showed you? And it's like a vacuum. If we open that closed, pressurized area, what's going to happen? It ain't like a cartoon, so it's not going to like come out and drip on your shoe. But it's bad, right? Herniation of any type in the brain in a confined space is not good. Oh, sweet. I got to give Dr. Graham a high five. Love it. Love to see it. So, all right, some other things we'll talk about. We're going to go through these at length, so if you need to revert back, you can. Is it a lot? I don't know. You guys have had some of this stuff before. Some of the medications, does any of that ring a bell? You've had analgesics, narcotics, psychotropics, anticonvulsants. Why does Valium get its own one? Benzodiazepines. Do those sound familiar? All right, you guys are crushing it. All right. Let's start TLO, ELO, because we're in a trade-off space, right? So we're going to talk really today just about history taking, how to take a good neuro exam, and things we want to do for a neuro exam. I'm going to expect you guys to kind of know some of this stuff already. Ooh, I got in trouble. So the first class I had, I was like, this is review. And they were like, you said that about everything, right? So we're going to go through it. You should have been exposed to some of this. If not, yo, we're just getting cooking, man. Where are you going? All right, good luck, brother. Yeah. I don't want your class. I couldn't stand it the first time. All right, sorry. All right, first step is define our anatomy, and then figure out where or what is the lesion. What does that mean? Define our anatomy. Why is that important in neuro? Why is anatomy important in neurology? Absolutely. So we're talking about CNS, PNS, which controls what? Everything. So if I'm coming to you and I have a deficit on my right upper extremity, what controls my right upper extremity? Granted, this is a convoluted question. It could be a bunch of things, but generally speaking, my left side of my brain. Right? Left controls right, right controls left. We understand that. If I'm doing that, I'm also slurring my speech or have word salad or broken, right? You talk Wernicke's broke as aphasia. Start putting that stuff together. That's powerful. You can start backwards engineering this thing to what is going on with this person's brain. So yes, we're going to do some neuroanatomy, straight stolen from your A&P course. So like, don't start sweating and be like, oh, I'm not going to ask you too many anatomy questions. If I do, I'll let you know which ones. But we need to be able to understand our anatomy and physiology. What part of the brain controls what specific function? For instance, what does the brain stem do? Yeah, like homeostasis. Yeah, like breathing, blood pressure, all that stuff, right? So if I'm my drunk patient and I have left to right shift, because your brain will shift left to right, then where's it going to go? Down. Herniation, your tonsils, right? Like an uncle herniation, and then I stop breathing. Is that bad? Am I usually coming back from that? No. What does that look like? You guys remember Cheyenne Stokes breathing? Remember that from the last class that I had you guys, right? Apneic breathing, Biot's breathing, all that stuff, right? Those are all kind of pieces of the puzzle of this. I'm your patient, I'm going to be unalived pretty soon. That's not good, okay? All right, taking a neurohistory. What are some things we want to consider? Are they capable of giving a good history? Who's not capable of giving a good history?
That guy.
My guy, my drunk guy. Who else?
Stroke.
Kids, Alzheimer's, right? So demented patients. So again, just things to consider. You guys know this, but it's a little bit different with neuro because we may ask, I could have a demented person. I did have a demented lady, 84-year-old, that came in with belly pain. She was telling me everything's fine. She had a perfect appendix, right? So is everything fine? No. I'm like, hey, ma'am, I'm glad you feel fine. But like 2 minutes later, I come back and she's like, who are you? I'm like, Chris, remember? Like your PA? She's like, no, I don't, right? So she may not have the capability or capacity to remember what's going on. So things to consider. Depressed, another one to consider. Demented, dysarthric. What is dysarthric?
Like your muscles that make, if you have a stroke or something, you can't make words.
Can't talk, right? Right? What else? Anything else to consider? So dysarthria, just for your own edification, is a disorder of articulation, stammering, or stuttering caused by a nerve deficit. So good. But yeah, I just say you can't talk for that, for those Bostonians in here. That was the book learned in answer. For me, it's like you can't talk, right? So you're dysarthric. What about somebody else? What about a witness? What if I had a witness to that guy that got hit with a baseball bat? Think he'd be helpful or she'd be helpful?
Oh, yeah.
Maybe. I don't know. It's probably their co-conspirator. They're probably robbing him. I don't know, whatever, right? But sometimes family members, right? Sometimes witnesses are going to be better than the patient. A lot of times that's going to be the case. And if you guys are scratching your head like it doesn't make sense, ask the family member. There'll be a plethora of information for you. So try to answer, is it a neurological disease? And then localize the problem. What are some things that kind of convolute that? What are some things, systemic diseases that may present like neurological issues? I guess what I'm thinking. But what's the big one that's the answer for almost everything?
Diabetes.
Diabetes, right? Diabetes, right?
Cancer.
What are our diabetics usually come in to see us for? Another stupid question to ask. Guess what I'm thinking. So they come and see you guys and they're like, hey doc, my blood sugar's low or my blood sugar's high and I eat like trash. No. They come in because they can't feel what? They have neuropathy. They have bilateral upper and lower strength neuropathy. Or what else has small nerves in it that like their penis. Yeah, they want to see you guys for ED medications, and you're like, your A1C is 10. It's probably suboptimal, right? So their eyes as well. Someone said eyes. Yep, they can't see. So blurry or double vision or diplopia. Good. All right, let's go. Timing, some things to consider. Sudden onset, possible slow improvement. It's not always, but consider vascular events, stroke, seizure, migraine. Gradual onset, think toxic, maybe they got poison, metabolites, infectious disease, inflammatory, or tumor, right? Tumors grow slow, but if they have a slow onset of headache or some sort of other neurological symptoms, something could be growing right inside, which is creating that problem. You guys will hear the terms like relapsing, remitting. If you're ever reading a question, can't tell you 100%, but if you're ever reading a neuro question for me and you see relapsing, remitting, just think MS. So it's an inflammatory demyelinating disease or multiple sclerosis. So patients, what does relapsing, remitting mean?
Going downhill.
Yeah, so it happened, yeah, exactly. Yeah, so thank you for playing. Yeah. This one, roller coaster, right? So they get an onset of it, right? Maybe they get some muscle weakness, unilateral eye symptoms or something, and then they get better. You're like, victory, I don't know what that was, right? And then they get it again, but maybe it's less severe, maybe, right? So they come see you the second, third time, and you're like, oh, this is interesting. Are they going to sit there and tell you, oh, I have relapsing and remitting symptoms? Nope, comes and it goes, right? Any history of trauma, why do we care about that?
That guy. That guy.
Yeah, and who are we going to ask if they have a history of trauma with like headache symptoms or neuro symptoms? Let's just say everybody, right, for the time being. Let's just say everybody. So if you're coming into your clinic and they have a headache and you are just hell-bent on figuring that this is a migraine or a tension headache, is it bad to ask them if they have any trauma? No. It's just a pertinent positive for you to kind of stash away in your exploration. So just something to consider, okay? Don't let them fool you. I have this massive hematoma that looks like a unicorn horn. Do you have any trauma, man? Like, no, I just woke up like this, right? Some of your young kids, young soldiers don't want to tell you this. But I had a kid at Riley who dove head first into like a bunch of rocks and smashed his head, and he had this huge hematoma. He came in, he had a subdural, he had a brain bleed. And I'm like, hey man, what happened to you? He's like, I don't want to tell you. It's going to be destruction of government property. I'm like, what? He's like, I heard if I hurt myself, I'd be in trouble. And I'm like, I don't know, man. Like, I'm just worried that you're going to die in the next couple seconds. So let's go to the ER. But, all right, what makes it better? What makes it worse? So what does this sound like? OPQRST? Do we need to belittle? Do we need to belabor this? You guys feel comfortable with OPQRST? Is anybody hearing that for the first time? Okay. Good. Qualities. I hate buzzwords, but yep, they're there for you. Lancinating, knife-like, radicular pain, ice pick, right? Or throbbing type pain. So some of our neuro stuff that this correlates to, like lancinating, knife-like pain. You'll hear with cluster headaches. You'll hear with trigeminal neuralgia. Patients feel like they're getting stabbed in the head. They're not going to tell you that. They're not going to say lancinating. They're going to say, I feel like someone's stabbing me in the head. Same with an ice pick. Does anybody have an ice pick at home? If you do, you're super bougie. I don't know. I'll have to try. Like most of us have like, I don't know, automatic ice makers at this point in our lives. Oh, I have to get my ice pick and chop it up. But anyways, you guys can, you can hallucinate and kind of think of something stabbing somebody with an ice pick. That'd be pretty painful, right? So, region of symptoms: headache on one half or the head only, right? So that kind of favors your. Maybe I'll take a swing. Migraine type headaches. So usually unilateral. And don't worry, like we're gonna hit migraines ad nauseum later on. So. Paralysis on one half of the body, so hemiparesis, what do you think of that? I would think stroke, I'd be concerned about that. Numbness down an entire limb, so radiculopathy, neuropathy. I don't know, that's a loaded question. Could be a herniated disc, like it depends on where it is. But, let's go back to like figuring out where that neuropathy or radiculopathy is, right? So the patient comes in, they have lower back pain. Every time they straighten their leg out, are you guys in ortho right now? You know, straight leg raise stuff and all that stuff. So every time they straighten their leg out, they get a sharp stabbing pain down to their knee. Or let's say down to their foot. Are we worried about an HMP and the L5S1 distribution?
Yep.
Are you guys just saying yes because you want to get this over with as fast as possible? Okay, thank you for being honest. I knew I could count on you. I miss you, man. Reunited. All right. And then stocking and glove distribution, what does that mean? Just like it says, guys, so your diabetics will complain about this, and they won't probably say that, but it's like from, as high as a high pair of socks go, it's a glove. Just think about that. So fingers and toes, feet, that type of thing. So that's a common one you'll see with your diabetic patients. Severity, right? You guys know this. Pain, 0 to 10, 10 being the worst pain ever. Quantify it for me. oh, they can't talk, right? Have them point to a long Baker face, like just they can always give you something, right? What if they say my pain is 20 out of 10? They're smiling on their phones, so you slap them in the face, and you're like, how does that feel? Like, oh, that was a 5, right? No, you do not do that. Like, just document it. That's what I do, right? So it's subjective. It's a subjective finding. Patient states they're 20 out of 10 pain after I explain the 0 to 10 scale to them. What does it mean? Whatever you want it to mean. Pain the patient's problem. Are you guys going to treat pain when you're out there? Anybody not going to treat pain? Let you know you're alive, right? I would encourage you to treat pain. Things are painful, right? I don't think if we have the opportunity to do that. My 84-year-old demented patient with a perth appendicitis, did she get any pain meds up until then? No. You think I gave her pain meds?
Oh, yeah.
Nah, she's not going to remember anything. Of course I did. God, your face. Of course I did, yeah. I gave her some morphine. I helped her out. All right, medications and allergies. What are they taking for pain relievers? How often? Dose duration, risk, right? Benefit, all that stuff. You know you're responsible for it. Psychiatric medications. Why does that relate? Why are we talking about that in neuro?
Crips.
Ultimate status, yeah. Did you guys talk about your psychotropes, your Gen 1, 2, antipsychotic medications? Do those have some serious side effects? Yeah, absolutely. So just something to consider. You will go to your patient and say, do you have any history of behavioral health related pathology? And they'll look at you square in your soul and say, nope. And then you'll go and look at their medications and they'll be on like Haldol, TID, or like Geodon. And you'll be like, oh, sweet. Why do you take this Geodon? Oh, I'm bipolar and schizophrenic. Do you take this? No, I stopped taking it, right? So just something to consider. So, any herbal supplements? What are they taking off the internet? Do y'all know that there were people buying tapeworms from Russia to try to lose weight? Was it bad at one point? Anybody want to raise their hand? Anybody do that here? This one time, guys, I tried it one time. No. Hey, you'll lose weight, but it's probably suboptimal. You guys, we got to ask those questions. Illicit drugs, so understanding some of the local jargon. This was embarrassing to me. Like when I first started practicing outside, they're like, "Yeah, man, I smoked some ice, so I scored some slap." I'm like, I don't know what any of this means. Like, can you slow down and maybe tell me? It's like, oh yeah. So just ask your patient, what does that mean? Like, what drug is that? How did you take it? Is another thing, right? Like, oh, I took it rectally. I'm like, I don't think you should do that, but to each his own. So, and then allergies, we know for sure. Past medical history, for sure, right? Get a good neuro medical history. Any headache disorders, diagnosable seizures, head trauma, drugs, alcohol use, CNS infections, meaning what? Meningitis or encephalitis. Why? Do those people tend to come back and see you with recurring infections? Yes, they do, sometimes. Psychiatric disorders we talked about. Toxin exposure, that's a good one, especially for the military. We may not know it, but do our, what were the tract ambulances? 113? Did the tract 113s catch on fire?
No,
People
never.
get stuck in there. What are they breathing in?
Good old MREs.
CO2, carbon monoxide, like nothing good, right? So what do you guys say when they come to you? The whole crew's like, Doc, we got a headache. You're like, God, man, just claim it on the VA. I don't know what to tell you, right? No, we got to be aware of that. When you pull that out, because we weren't with them, they probably need high fluid too. You need monitoring. So just something to consider. Social history, pause for effect. Travel. You guys think about travel. You guys are graduates of the infectious disease course here, aren't you?
Yeah.
Are you taking it now?
Yeah.
How are we liking that one? It's like, I have a headache, I'm fatigued, and a cough. Like, where'd you go? China. It's got to be this, right? It's the Wuhan virus. You're like, oh my God, how did you know that? They all present the same, and it's like, well, where do they go? Right? Where do they go? Were they spelunking in a cave? You're like, what does that mean? You guys eat bat poop? Yeah, matter of fact, they did. We miss 100% of the questions we don't ask. So, family history. So apples and trees, you guys have heard me say this before, but mom and dad have a history of X, Y, and Z. Genetics plays a strong component in this as well. So mom and dad have Alzheimer's, early onset frontal temporal dementia, ALS, something like that. You got to keep that in mind. So, any family history of psych disorders, age or cause of death we want to know, and then anything else you guys can do. ROS, Any changes in weight gain or weight loss, fever, chills, nausea, vomiting, diarrhea? What do you guys think about when you hear weight changes? Drastic weight loss, night sweats, pain that wakes you up at night? TB, cancer. All right, good stuff, guys. What was TB in? Are you guys doing Poland too?
We're done with Poland.
Oh, nice. Are you in Poland this semester?
We're done with it.
Oh, victory, man. Yes, I'm getting you guys late, so. All right, I feel like we just said this, but headache, any loss of consciousness, speech or related function, memory loss, insomnia, attention and concentration, or disorientation. So, again, just something to consider. I'm going to package this all for you guys at the end, and you can have a cheat sheet if you want, or you can memorize it. I don't really care. I'm not going to ask you. Regurgitate all the questions. It's not a test question, so I'm not going to teach you on that one. So, cranial nerve. Y'all think you need to know your cranial nerves for this class?
Oh, yeah.
We did those that the last class, though. You guys are like, you clept out of that one, right? So like, I don't need it anymore. Start brushing that stuff off. So my goal for you guys, aside from smoking this class, getting A's, moving forward, is that you guys have a good neuro exam week. So when you get called bedside and they're like, hey, I think this guy's got like a neuro deficit, you're not like hold on. Let me grab my coffee and my stick of gum, right? You're like, cranial nerve 1. Who likes cranial nerve 1? Is that anybody's favorite cranial nerve? That's good. Cranial nerve 1 is just trash. Anyways, all right. Any facial numbness, deafness, dysphagia, so difficulty swallowing can oftentimes be the first sign of a stroke. That was kind of embarrassing when my colleague sent a dysphagic patient to GI to get him scoped to rule out a full body, and they sent him back and said, hey, dude's having a stroke, man. You might want to work him up for that, right? And he was having a stroke. Dysphagia was his only symptom. But he also came in and said, I ate a big piece of steak and it stuck in my throat. So that's anchoring. God bless you. Very good. Yeah, that one was better. All right, review of systems, limb and motor sensory. You guys let me know when you're ready for a break. No, it's way too early. All right. Paresthesia, which is what? Yeah, pins and needles, burning, tingling, or tickling sensation. What is radiculopathy? Nerve pain, usually one or more or one plus nerves, usually near the nerve root. Paralysis, y'all know what that means. Tremors, what's a tremor? Involuntary movement, right? So shaking, right? Weakness, we all know what weakness is. If you don't, I'll show you. Bad joke. And then dyskinesia, involuntary movements. What is dyskinesia? What can that look like? You guys caught tardive dyskinesia at all? What is that? Yeah. Y'all should be just making mouth faces at right now. One person, guys. That's it? Oh, it's because I get you at the end of the day, right? So I used to think all my old people with dentures that were smacking their dentures around was tardive dyskinesia, and then they're just playing because they didn't fix it and forget it with the polydents. I'm like, everybody has this. So like, no, man, that's their denture. So anyway, don't make that mistake. All right, what does the cerebellar portion of the brain do? Fine movement and ataxia. How do we evaluate that? Walk. Gait. What else? Taught you guys this too. Thank you. Oh man. Finger to nose. What else?
Balance.
Yeah. This is good for you. What else? For the win? Guys, seal it in. Come on. I need some. Yeah, Romberg. Thank you, man. In the back. Love it. Love to see it, man. Love to see it. All right. Psychiatric history. We kind of talked about this already, so I'm going to push through it. Red flags. Worst headache of my life. What are you worried about? Yeah, absolutely. Absolutely. I had a student, on last week, and we're doing a mock OSCE this week, I apologize. And we're going through it, and he had a headache. And it just so happened to be me. I don't know if he was nervous. I'm like, bro, you're going to be fine. Just take a deep breath. And he asked a question, like, is this the worst headache of your life? And the patient's like, I don't know if it's the worst, but it's up there. What do you think he did? He's like, sir, I'm going to stop right here, and I'm going to send this person to CT ASAP. And I'm like, all right, let's see where this goes. We're like, strap in, this ought to be fun. And I'm like, all right, I'll play your silly game. I am radiology calling you and asking you what your neuro deficit was. You're like, I don't know, he had a really bad headache? Okay, awesome, I'm going to spin him for you. Now I'm neuro, and I'm here to see your patient. What was your deficit bedside? I didn't do a neuro exam. I'm like, whoa, this is It's okay. Did he pass? Of course he passed. Of course he passed. And then at the end, he started getting more. I'm not gonna tell you who it is. So I can't do that. But then at the end, he's like, all right. So I was like, all right, man. CT non-con normal. Are you still worried about a stroke? This could be a ischemic. And he's like, maybe. I'll keep it on the differential. You do that. He goes through. He starts getting pulsatile, rapid onset, unilateral, debilitating, photophobia, which is a migraine, right? And he's like, again, sir, I think this is a migraine headache. And I'm like, cool. He's like, I want to give him an IV, and Toradol, and Reglan. And I'm like, do you want to ask if she's pregnant or allergic to any medications? He's like, yeah, I'm gonna do that first, right? So, it's all good, man. It happens, right? It happens. He's like, somebody gave somebody Toradol when they're pregnant. So we should try not to do that. Like, that's not, we don't want to emulate that. So. All right, sudden blindness. What do we think about? Trauma. Diabetes, usually slower, but maybe a stroke, retinal artery occlusion, detached retina, something with the eyeballs. This is not pathognomonic for anything. You guys, I can't tell you, somebody is serious, sudden blindness. You're like, let's stroke it out, right? I would consider that for sure. Back pain worse at night. Keep cancer in differential. Bowel or bladder incontinence. Cardiac blindness, saddle anesthesia, and then suicidal ideation of plan. Suicidal ideation of plan. Yeah. Do we have a suicide problem in the military? Yeah, we're like destroying the civilian population. That's not a good thing. So, if you guys, I'll soapbox this for a second. So, you guys are all in Clint skills now, right? Or Clint course. Where am I going? If you guys get SI, and we had SI with plan, or SI with no plan the other day, you guys are practicing. If you guys are worried about it, don't chance it, right? Go grab, you'll have costs embedded if you guys are active duty. If not, make a phone call. Err on the side of caution. You know what I mean? The worst thing would be you're not sure. We had this big talk with my group, and they're like, yeah, it's kind of a soft plan, better off dead, not want to be here, blah, blah, blah. But I didn't feel comfortable. You don't feel comfortable, make the call. Ask your brother and sister provider, ask your attending physician. Don't put that on yourself. That's bad juju. Because if that person goes home and kills himself, that's obviously terrible. How are you going to? Terrible, right? So, all right, that's enough. You guys are probably got enough of that with sites. All right, focused physical exam. Some things we're going to do. Obviously, you guys, we're going to talk MMSE here in a second. But cranial nerves should be refresher for you guys. Reflexes, actually, all this is the opposite. So, general exam, physical impression, vital signs. Okay, head and neck, any rash, skin is intact without erythema, most in duration or breakdown, right? You can see some of this stuff there. So palpate the head, right? We're feeling for any fogginess or tenderness, trauma. Watch out for depressed skull fractures. You don't want to poke through and, oh, it's like great. Let's touch this. That's not a good day. Temporal artery tenderness. So you guys know that from physical exam class. Auscultate for bruits, right? Stenosis. If there's plaque in the arteries or atherosclerosis, there's probably more propensity for possibly be a stroke, especially if the blood pressure's through the roof. So, who gets heart and lungs?
Everybody.
Your neuro patients get heart and lungs? So that should be 2 points, right? Everybody, no matter what. Physical exam first and heart and lungs always. So, all right, MMSE, I'm going to fly through this because I actually want to do an exercise with you guys. I know you're like, seriously? It's time to go home, right? Your MMSE is going to, have you guys been exposed to the mini-mental status exam? That's all right. So, it's going to talk about your level of consciousness, orientation, speech and language. You're like, whoa, slow down. Memory. I do want you to star this one. There are 3 time scales, intermediate, short-term, and long-term. We'll talk about it in the review, but there's a couple questions on there. Funds of information, historical current events. All right, so if you show a picture, if I showed you guys these pictures and I was like, what's that bottom picture? Do all of you know that, though? Is there somebody in here that's like, I have no idea that's Washington crossing the Delaware? So just remember education level, where somebody's from, and experience as well, okay? So it may not be as intuitive as everybody thinks. Insight and judgment, right? Usually ask them, hey, this building is on fire. Like, what are you going to do?
Run.
Evacuate is a good answer. All right, stop, drop, and roll. No, you're not on fire. The building is. Right? So if in this situation, what would you do? If you found a wallet on the sidewalk, what would you do? What would you do? take the money, and you'd probably try to return it, right? You'd rather return it to somebody or turn it in. Or look at their license and call them, I guess. Huh? Doesn't have their phone. Hunt them down. I don't know. Abstract thought, what's the difference between what's similar between apples and oranges? They're fruits, desk and chair, right? List all animals with 4 legs, those type of things. So, and the reason I'm not having you guys memorize this is it's on a sheet for you in a second. So calculation ability, serial 7s, or give them an easy problem. What's 5 plus 3? Is anybody with me? It's not 7. Somebody said 7. So 8, right? So just some easy stuff, right? So your MMSE, which I'm going to pass out in a second. Actually, I'll have you guys do this now. I'll have you guys partner up. The reason I do this is not just because I'm crazy, that's maybe true as well, is when I left phase 1 and went to phase 2, just take 1 for every pair, okay? So you're going to partner up with theirs next week. When I left phase 1, and you guys will do this as well, when you go to phase 2, they're going to be like, hey, go do an MMSE on somebody today. We didn't learn that phase 1. They suck in phase 1. We didn't learn anything. They just beat us, right? And that's fine. But I would rather you guys be prepared. So this is something that hopefully you'll remember, and do not memorize it. It's on your phone. There's the MMSE. There's the, what's the other one? The MOCA, or the Montreal Cognitive Examination. These can just come up on your phone. They're easily reproducible, and you can do them serially to see if somebody's having like a defect or a deficit, okay? There it is. What I'm going to do, I didn't give myself one. That's awesome. I can't read that. I want you guys to partner up, and one of you will do this for the other person. So one of you will be the patient. Ah, perfect. One of you guys will be the patient. The other one will be the clinician or provider. And you guys just give me an MMSE score at the end. So it's scored out of 30, as you guys can see there. I'm not going to go through it individually. If you have questions about it or something that makes sense, ask me when we come together. I'm going to give you guys 5 minutes to do this. Does that sound doable? And execute.
Far away.
It's October on a leap year in 1979. How old is the patient? They were born in 1936. What's the year? 2026. What's the season? Date? Okay. Where are we? What state? Town? What floor of this building? Does the basement count? All right.
Yes.
What is this? What is this? What is this? It says name 3 objects. 1 second to say each, then ask the patient all 3 after you've said them.
So you do 1 second to respond, and you ask for the 3.
Spell world backwards.
DLROW.
What were the 3 objects I asked you? Name a brand of a watch. Name a pencil.
Number 2.
Okay. All right, repeat what I say. No ifs, ands, or buts.
No ifs, ands, or buts.
Okay. Fold that in half and put it on the ground. Right here. It says follow 3-stage command, take a paper in your hand, fold it in half, put it on the ground. Close your eyes, touch your left ear, and rub your right knee. All right. Solid. All right. Write a sentence. Say, I will pass my next test. And then redraw those objects to the right of it.
Redraw it.
Redraw these right here.
Congratulations, you got a first. You are
I'm getting an absent seizure right now. Balance is backwards. Subtract.
So it's spelled world backwards.
Well, backwards hard.
You guys feel good about that? I had a great question. I thought it was a good question. Name a pencil or watch.
Yeah.
It was like Ticonderoga, Seiko. I'm like, so you possibly the best answer I've ever had. So you can just say, what is this? Or what? And if you don't have one, what would somebody typically wear on their wristwatch, watch? Ticonderoga brought me back. Like your number 2 pencil.
Yeah.
That's pretty good. That shows some depth. All right. Anybody get below a 24? Ooh. You're high functioning at least. All right, so what do we care? Why do we do this? You guys can see the bottom. I don't know if it's on your sheet. It should be, but 24 to 30, no cognitive impairment. 18 to 23, mild, and then 0 to 17, severe. Okay. Why do we do this? Why did I have you do this? And then I want you to be exposed to it.
We're in neuro class.
Baseline, right? So baseline, this person gets admitted. We start to see cognitive changes, but they're not sure what they are. Can I do this to the same patient an hour from now? 12 hours from now? Tomorrow? And I can start seeing trends, right? Like, hey, something's not right with Rogers. Like, he seems like he's spiraling downhill. So maybe it's not dementia. Maybe he has delirium. And there's something else going on. So, or maybe it's both. Those are fun patients. All right, so keep that in your toolkit. And like I said, you guys all have these fancy apps on your phone where you just bring this stuff up. If you don't have them, you'll get them by FaceTube. Don't worry about it. Because if someone asks you to do that, the worst thing you want to do is go hunt down the computer and print it out. You can print some for you ahead of time, or just use your phone, bring it up, MMSE, boom, score. I think they got a 25 based off these questions asked. Any other questions on administering that? Did it feel weird doing it? Felt judged? Don't judge me, right? Well, the MACE, I think, is way more in-depth. Does the civilian world use MACE? No. I almost wish they would. And what's a flaw with the MACE for all my medics out there?
You know it.
Can you memorize the MACE and beat the MACE? Yeah. So, again, can you memorize this and beat this? Sure, whatever. But, I don't know. All right. Let's do cranial nerves, and then we'll take a real break and get up and walk around. So everybody remember cranial nerve 1, right? Sniff and smell. Good. Cranial nerve 2, visual acuity with correction, right? So I don't know, the other day, like, yeah, I think it was, I'm just hating on the seniors. You guys are way cooler about it. They were doing visual acuity, but made him take his glasses off. And I'm like, bro, he can't see. He's blind, right? So they can keep those on. They're like, oh my God, I think he's really having a stroke right now. I'm like, nice, get him an energy drink. Visual fields by confrontation, how do we do that? Nice, you guys are starting to play now. You're starting to play, some of you, not everybody. And then take a look at the back of their eye, right? What are we looking for the back of the eye? Don't give me that cut to this ratio. What do I really care about in nerve?
Nicking.
Hemorrhages, exudates, what else?
Cotton wool spots.
Sure, cotton wool spots, all that good stuff, right? So what about optic nerve swelling, papilledema? Like if I have swelling in my brain, is one of the places it can push out my eyes. Yeah, that's pretty neat. Yeah, exophthalmos, right? Yeah, you'll see that when they're bugging out on you. You're like, whoa, stop doing that. 3, 4, and 6. So remember LR3, XO4, LR6, SO43. Y'all remember that, right? So pupils, extraocular movements. Trigeminal, right? Ophthalmic, maxillary, mandibular area. Clench your jaw, masseter muscles. And then facial, right? How do we do this? Copy me, right? Just making some funny faces. Usually when you do that, people are like, what is going on? So usually when I break out my neuro exam, I usually tell people kind of, hey, I'm going to check your cranial nerves, just kind of do what I do, or follow me. If you have any questions, let me know, right? So it just makes it so much easier. Let's play Simon Says. Like, I don't know how to play that game. So, raise your eyebrows, close your eyes, smile, puff your cheeks, right? We're looking for symmetry, right? Vestibular cochlear, close your eyes. What side do you hear this on? It's my right, it's my left, it's both, right? Or you can stand behind somebody and be a creeper. I don't care if that's what you want to do. Right? You can stand behind them and whisper. Someone in the sophomore class was telling me in dive medicine they were taught to do it out here and then come in. That was new to me. So either way, we're just grossly assessing it. So you guys just keep it close. That's fine with me. But I thought that was kind of cool. Taught me something. So 9 and 10, right? So open your mouth, stick out your tongue, say ah, gag reflex, everybody's favorite, right? When do I actually do a gag reflex on a patient? What do you guys think?
Every time.
Every time? I'm just trying to keep it real with you. Should I do it for every patient to make sure that cranial nerve 9 and 10 are intact? What do you think? How about an unconscious patient that I think has a neuro issue? Yeah. And neuro will ask me, they'll be like, have you checked his reflexes? Specifically his gag reflex? And I'm like, no, I haven't got around to that yet, but I'm going to go do it right now. So, but that's going to be important to take a look at. So where do these cranial nerves originate from? Y'all remember? The brainstem. The brain. That's not a bad answer. The brainstem, right? So these are 12 sets of nerves that originate from the brainstem that we're testing bedside. I'm not trying to sell you guys on something. That's kind of neat, I think, right? So you can directly from the brainstem to see what's going on here, bedside maneuvers. So, 11, spinal accessory, right? Shrug your shoulders, turn your head, sternocleidomastoid, and then 12, hypoglossal. Stick your tongue out, looking for atrophy, fasciculations, position, and strength. What's up, my man's tongue around here? It's a little deviated, right? So we'll look at some other examples when we talk cranial nerve disorders a little bit later. Motor exam, strength, graded on 5, 1 through 5. 5 being? So what would I expect all you guys to be? 5. 5. Right, 5 out of 5 bilateral upper and lower extremities. What do you think? I hope so. I hope so. Probably TMI, but my foot's a 4 right now, apparently. So I got a kick out of that. I told you guys last time. Yeah.
Got a kick out of it.
Don't laugh. I had knee surgery. I told you guys I had knee surgery last semester. So they crushed my peroneal nerve. So now I went there. They're like, at least it works. And I'm like, thanks, guys. Army medicine. But they graded it. And they're like, I think that's a 4. And I'm like, whatever, man. They're like, it'll come back. Just keep praying at nighttime. Jesus loves me. All right, pronated drift. What do we do for pronated drift? Close your eyes. Keep your hands up. How long do we hold them? Yeah, no less than 10. 30 seconds is a long time. Now what are we looking for? Yeah, make sure they stay up and equal. So they both fall down. one falls down, that may be a sign of a stroke, so let's keep that in mind. So. DTR is graded 0 to 4. What's normal? Let's remember that. That's good stuff. We're going to go through some of the, have you guys, is this repeat for ortho? Have you seen this on ortho yet or not?
Yes.
He tells me you have, him being your ortho instructor. Okay. I would like you to know, generally speaking, like C5 nerve root, right? So abduction of your deltoid, biceps tendon reflex, and your sensation is your upper outer arm. That should be kind of, at this point, if it's not, just take a look at it. Like, just take a look at it, right? I'm not mad at you, but you got to get after this one. So C6, wrist extension, brachioradialis is your reflex, and then the lower outer arm, right? 7, wrist flexion. Triceps tendon is your reflex, and then what sensation is C7? Yeah, shooters, right? Good. C8, finger flexion. What's your reflex for C8? Wouldn't that be an easy question? Reflex for C8 is not, right? So there's no reflex there. And then sensation is your inner forearm. So L4. You guys remember these? Is this going too fast, too slow? Like, just tell us the ones we need to know for the test. I will. We'll get there. Don't worry. But you got to have an understanding. This goes back to what is the patient presenting. So if you're saying they have an absent reflex in L4 and you don't know what the reflex is, we're missing the bus. We've missed the bus somewhere. Okay. So your motor function L4, tibialis anterior foot inversion, it's your patella tendon, and then you guys can see the sensation there, L4, the inner foot. L5, I'll pause for effect. Just note there's no reflex. S1, reflex, Achilles tendon, peroneus longus, peroneus brevis, and you guys can see the sensation there. So this is the one that I think they sniped on me. So. All right, a couple more reflexes. Cutaneous reflexes. Are you guys familiar with the plantar reflex? Also known as Babinski. What's normal? Curling your toes. What's abnormal? Right. So again, I just want you guys to know that. So, and this could be This could be CNS pathology from a lower motor neuron. We haven't gotten into that yet. This just could be an initial clue that something is wrong. Superficial abdominal reflex. Okay. This is T8 through T12. This is taking a sharp object and you're not stabbing your patient, please don't do that, but gently stroking it down their abdomen and the muscle should shift towards it. You guys think I'm going to see this like a 400-pounder? No? This is a little shade of a 400-pounder. What about a 45-year-old man that's got a little fluff on him? Think you're going to see this? And me? No, probably not. Some of you guys, 6-packs, you might see it. Go home, try it out. Chromosthetic reflex, what's that? Stroke the inner thigh, retraction of the ipsilateral testicle, right? So not the contralateral one, the ipsilateral one. So what is that important for? Torsion, L1, L2 for my class, but yeah, absolutely. Bell clapper deformity, high riding testicle, lack of chromosthetic, positive prensine. I would probably worry about torsion too. I'd be grabbing an ultrasound ASAP. Anal wink, L2, L3, or excuse me, S2, S3, S4. What is that? We talked about the bulbar cavernosus reflex, didn't we? Bulbar cavernosus. Guys. Yank of the crank, into the wink of the snake. We didn't talk about any of this stuff. Nothing? You'll never forget that. And you're going to say it during a trauma and be like, what? Oh my God, we're touching. Yeah, so if you lightly pull on a penis in a trauma patient, the anal wink should take place. That's called the bulbar cavernosus reflex. You guys we didn't talk about this last class? I apologize. That's real. Yank of the snake, the yank of the crank gets the wink of the stick, right? So I'm sorry, I didn't make it up, but are you guys taping me today?
No.
All right, good. Yeah, do not try that when you're at home. But clinical relevance. Let's put it so you're boarded and collared and you're coming to me and you're unconscious. Is that a way I can figure out neurological function of L2, S2, S3, S4? Yeah. Worried about spinal trauma, right? Absolutely. These are things that you guys, that's what I'm saying. Understanding what what anatomy is linked to this is important to me. It should be important to you guys too. All right, Babinski we talked about, downward fanning good, upward fanning bad, or possibly concerning. Some primitive reflexes, but this isn't peds. So we do want to know this. You guys will know this in peds. Sup response, lightly touching center of the lips, right? Causes, anybody have little babies in here? Okay, so you can practice on that. When you guys get the peds, you'll see it. But root response, lightly touching the corner of the lip. They usually turn towards this kind of feeding responses, right? Innate reflexes. Grasp response, what happens when you put your finger in a baby's hand? So you grab it. And then this palatal response, right? This is a contraction of the mentalis muscle, ipsilateral to a scratch stimulus, diagonally applied to the palm. That one's a little bit more in depth. Why do we care about this stuff? See? An adult should not have this. And we're going to talk about dementia patients that have atrophy of their cerebral cortex. If you have a defined and mature cerebral cortex, you overcome these reflexes. What happens if I start seeing these come back in somebody that I'm concerned about with dementia? Yeah, we could have loss of brain matter, right? Atrophy of some brain matter. So this is just something to kind of consider. It's kind of like that reverse aging process. You know what I mean? So just something to consider. Sensory, pinprick, sharp, dull, light touch, vibration, proprioception, 2-point discrim. You guys remember all this? Radial, median, and ulnar. So rock, paper, scissors, right? So what's rock? Radial with paper. Ulnar. What's scissors? Medial. I think I just said that backwards. I think I just screwed you guys out. That's what I'm going to you guys. There's only one left. So rock is medial. Paper is radial, and then ulnar is scissors. Okay. And then what is? Did you guys learn this one yet too? Interosseous. Okay. So that's just that was an easy way to memorize it until I just hijacked it on you. So just one more time: rock, medial, paper, radial, and then scissors. Ulnar. Okay. We're there. Sensory landmarks: T5, T4, T5, nipple line. These are good to know. And these were in our last test as well. I think I had you guys. T10, umbilicus. Those are easy. Coordination and gait, RAMs, rapid alternating movement, dysdiadochokinesia, finger to nose, heel to shin, and then walk your patient, your gaits. Okay, so that's your cerebellar stuff. There's a way to put it all together. That's everything we just talked about in an organized fashion. Let's take 5 minutes or 10 minutes, and we'll come back and talk this last part, and we'll be done.
Oh. 14 days. Come on.
For like 5 minutes, I'm like, I was like, yeah, I just haven't heard that abbreviation.
Shoot. Shoot. There we go. I think they go in order. Like if you do it in order, like rock, paper, scissors, then like it's in alphabetical order.
I just call it Mr. U.
And that would do.
It's on the what you call it, handout too. Handout. What you gonna give us?
Well, it's official. Time for retire. Traffic that I'm gonna catch. Horrendous. I see. Oh, wait. Alex. Oh my god. Putting cameras on the potty? Hey, get down over there.
I think that's called selection.
Brett. I don't know. That probably has like that cell yeah, they can. But unfortunately, they ask me like information back. Spanish.
I wonder how big some.
I mean, for a boy, it would be at least okay. For a girl, green, I was like,
It's harder.
I think that you would say no.
The higher the number, the higher the percentage. But it stops at like 41 with 6. That's high. To me, it's drops like I'd like to die
I'm waiting to see if it says.
Degree, like, nursing degree, everyone hands in.
Actually good.
Exactly, right. Counseling,
I set up a failure with the hearing on phone skills at one time. He was like, "Let me know when you hear this." I was like,
I came out.
"I guessed right." He was like, "Good job."
Which one do you hear from?
It's like, it's out my ear.
Hey.
Instead of whispering.
All right, good. Rotating that.
He's like, left.
you try to wait.
Just pull out a little black book.
Usually I know what you're talking about, but no, I'm just with you. Run.
Alright, we ready? Ready? Nothing too scary yet. All stuff to try to review for you guys. So, okay, let's go. So we're just gonna, the last part of this is just diagnostic testing and studies that we're gonna talk about. Because throughout the course, we're gonna reference some of this stuff. So just alright? Yeah.
Sir, slides are not.
Slides aren't up. Thank you for telling me.
Slides are up.
Slides are up.
All right, here we go. So LPs, you guys may or may not have talked about before. So indications, some of them, infection, meningitis, encephalitis, subarachnoid hemorrhage. What are we going to see with the subarachnoid hemorrhage on CSF? Blood. Xanthochromia? Good. Dementia, malignancy, MS, intracranial pressure, opening, ICP. What about the other stuff? So what kind of clues can it give us for dementia? Yes, good. Yeah. So like beta amyloid or tau proteins, which we'll talk about. Great. Are you guys going to see those? No. We're going to send them to the lab. We're going to nerd out and figure it out. What about MS? MS, there's one we'll talk about later, but oligoclonal bands, right? So banding will be in there. All this stuff is neat to know, and you guys may or may not have talked about it in Clean Lab, but we should understand that if we're ruling stuff out, like let's say we're LPing somebody because we're kind of in our workup, not really sure what's going on, could be meningitis, could be something else, and it comes back and says they have oligoclonal banding. We don't want to be like, that's a meningitis, right? So we got to kind of be able to understand some of the vernacular that the lab's trying to tell us. You guys remember? Actually, I don't want to waste your guys' time right now. We'll talk about meningitis the second block, but y'all remember? Did other instructors make you guys look at CSF panels coming back? Whether it was okay, so I won't give you that and say like, what is this? But I'll give you somebody with a headache, neck pain, and a fever, and I'll give you the results, and you guys will be able to piece that together, whether it's a viral or bacterial meningitis. Studies prior to LP, thank you, Dr. Kevin Graham. So always get neuroimaging prior to putting a needle in someone's back, right? So we want to make sure there's no mass occupying lesion or active bleed, okay? If they have a coagulopathy, if low platelet count, what are we going to do? Can't LP them? If I need to LP you because I think you have meningitis or a possible life-threatening etiology and you have low platelets, what should I do? Give them platelets. Yeah, absolutely, right? So I'm going to give you platelets and I'm going to proceed to stick a needle in your back and rule out meningitis. Does that make sense? Okay. How about lack of cooperation in the patient? What does that mean? Yeah. So that's a tough one. Your kiddos, I would say pre-sedate them. Don't try to fight somebody by sticking a needle in their back. How's that going to end up? You're going to get kicked in the teeth. You're going to lose some teeth and spit out some beautiful chiclets, and you're probably going to hurt the patient, so just be careful. LPs and meds, so warfarin, contraindicated. We want to correct, stop 4 to 5 days prior to LP, right? And then we can correct with FFP if we need to, INR in range. ASA and NSAIDs, there's no significant added risk. Circle that one for me. So if I give you guys a patient on your exam, and I'll say this later as well if you're sleeping right now, and they're on Motrin, but their meningeal signs are out the wazoo, are you going to tap them? Yep. It's not contraindicated, right? So good. Plavix, okay, discontinued 14 to 7 days. LP, left lateral recumbent or right lateral recumbent, I really don't care. Is there another way you could do this as well? Yeah, sit up forward, lean forward on a bed rail. Just be careful. If my patient's obtunded and they're in altered mental status, do I want to sit them up and lean forward? Unless you want to practice your suturing skills. I don't know. Let's split their head open. Like, they didn't have a brain bleed, but they do now. So just put them in the left lateral recumbent position and go to work. How do I find this anatomical space? Yeah, the PSIS, right? So what if they're like super big and you can't find it? Try harder, you'll find it, right? So PSIS, usually move medial to that. We'll talk about that in a second here. So, post-dural headache is a complication. We're making a hole in there. They can leak CSF. So about 10 to 30% of patients will get this, post-dural headaches. Increased risk with females, right? Younger age. Causes a drop in their CSF pressure. Treatment, you guys can do supportive analgesics, NSAIDs, Tylenol, caffeine, or an epidural blood patch. This is where you take some of their blood and inject it back into there so it clots out. I've had great results doing that. Epidural blood patch are going to come to the ER. I've had a patient come from the ER the next day with this, and I gave them a gram of Tylenol, 800 Motrin, and had them drink a Mountain Dew, and they were like, it was like Lazarus. They were like, I feel great. You saved me, right? I'm like, did I just prescribe Mountain Dew? Like, I've never done that ever. But Mountain Dew, for you guys that don't know, it'll rot your teeth, but it also has a good high caffeine on it. So I was like, hey man, slam this as fast as you can. They're like, really? Did you see this in a study? I'm like, no, I'm making it up as I go. It worked. So electroencephalography, what is this? EEG, anybody's own words? Brain waves, like electrical function of the brain. So what are our contraindications? Who cannot get one of these? Everybody can get it. So there's no contraindication. So if you're admitting somebody or you're concerned about first-time seizure, right, I may rule everything out in the ER, God bless you, labs, RADs, CT head, CTA, everything looks good. I may admit them for MRI, MRA, and EEG throughout the night. So if they go throughout the night and there's nothing, everything's normal, does that mean they don't have seizures? No, it just means I didn't catch one. So they have to have a seizure with that crazy getup, but all those wires on their head. So, all right, non-invasive. There's no drilling into the head. Just make sure you guys know that. So, has anybody had a sleep study in here? So it's similar to that, but a little more wires. So you I always get a kick out of it if you admit someone to medicine, they put this on them, and then like you put this guy, and you're like, all right, man, go to sleep. Like, I don't know if you guys can sleep like that. For me, it would just drive me nuts. You got that all over you. Nobody else, just me? All right. Anyway. An EMG or NCV, so your electromyography or nerve conduction studies. Anybody have one of these? These aren't real. So EMG records intrinsic electrical activity within muscle, and then NCV is a nerve, right, point to point. So you essentially put a needle in one area, send electricity down a nerve or muscle to another area that measures the conductivity of that. Why would I do that? It seems medieval. Neuropathy, radiculopathy, atrophy. So I think I told you guys last class. If I didn't, I'll share it again. But I had some rare. Did I say about my Parsonage Turner voyage? Oh, it was a blast. It was a blast. 2020, my chest and my triceps just started atrophying, just out of nowhere. Like, what didn't feel sick. Literally was starting to disappear. Like, I noticed it because I'd be on the bench and I'd be like, yeah, I know, I'd try to work out sometimes. My right arm would be like way stronger. And I'm like, something's up. And then my wife's like, what's wrong with your body? And I'm like, it's a dad bod? She's like, no, something else is going on here. Like, your left back is just disappearing. And it was rowdy. It was just atrophying here, and then my tricep would just fasciculate all day. And I'm like, I should get this checked out. Like, I should go get this checked out. So they put me on steroids, got better, did an MRI. They said I had entrapment of my brachial plexus, which I didn't know why. And they're like, you know what? Let's send you for an EMG. So they put needles in here, ran electricity down, and they're like, yep, it's not conducting normally, so we think it's this Parsonage Turner syndrome. Here's your options. We can cut you open from the front and try to decompress it, or we can just wait. I'm like, I'm going to wait. I'm just gonna wait and see if this goes away. And it did. It was weird. It was idiopathic and it went away. So, but the EMG, I say all to say, the EMG and the NCD was kind of neat because you're sitting there. Anybody have a TENS unit? So everybody knows TENS units, but it's similar to that, which you're contracting your muscles, but you're not doing anything. You're like, that's kind of weird. Okay, I digress. Are we going to be doing this as family medicine providers? No, we refer to neuro. Same for our EEG, right? So I just want to make sure I'm not freaking anybody out. They're like, well, I'm going to have this opportunity? Like, you guys can prescribe TENS units out the backside if that's what you want, if you think it's helpful, but we're not sticking needles running electricity through anybody's muscles. Skull x-ray, trash. Why do I say that?
Can't see anything.
Can't see anything. If you're worried about like a skull fracture, what do you think you're gonna need to follow this up with anyway? CT. So if I ask you guys a question, like what would be your best study of choice initially on a head trauma, don't choose skull x-ray. It's one of the options. Like, put a big X through it. I have to tell you guys this because it's there. But it's not gonna get you anything. So, okay? It's in the literature. But you can see there, usually would need a CT or an MRI as well. CT, outstanding, right? So computed tomography, I think this is great. How long does a CT of the head and neck take? Seconds, right? 10 to 20 seconds. So your patients are going to be like, oh, I'm freaking out, I can't go in the tube. That's an MRI, it's going to be 20 or 30 minutes in the tube with the loud noise. This you're not going to know if it's 2 seconds through the donut, okay? Actually it says 1 to 2 seconds, but if you're getting the head and the neck, this is just for brain studies. All right, indications, stroke, subarachnoid hemorrhage, tumor, mass, anything from mass you're going to pick up on there, trauma, and then dementia. You can also see atrophy as well. So complications, yes, right? So I do practice emergency medicine, but I'm not pulling triggers on everybody, every 25-year-old that comes in with a headache with a normal nerve. So I'm going to make sure you guys see the balance there as well. And we talk about that, why, a little bit later when we get into headaches, like why don't we just CT everybody? It's because of this, right? So I don't like, especially my young female childbearing ages, I don't like to zap them. Like eventually I'm going to give them cancer, right? When they come in and they have like 7 CTs in the last year because they come in for migraine headaches, don't be the 8th. Just be like, I think let's treat you first and then reevaluate you. So, contrast nephropathy, so check their kidney function. Sure, a lot of protocols will be they won't do the CT or push a contrast load until they get a GFR. With my patient that came in the beginning of this lecture, do you guys remember what his kidney function was? I didn't tell you. His GFR was like 3. Like all 3 of them, right? Do I care about his kidneys at that point? He's going to get dialysis anyways, is a good point. So none of that really came into it. But they'll call you and be like, hey, dude in 12's GFR is 3. You still want this? I'm like, yeah, he's ESRD, dialysis. We're going to dialyze him anyway. So no, thank you for checking. Don't be mean to them. But if they're allergic to it, protocols, check your protocols. If they're allergic to it, you absolutely need to do it. You can't get around it. Pre-dose them with a steroid and Benadryl. Wait 45 minutes. It's Christus's protocol. Baptist was similar. So steroid, H1, H2, 45 minutes and wait, and then do it. But there's not a whole lot of true, they're out there, but contrast allergies. What does contrast do when you push it somewhere? Anybody know? You guys talk about this?
It makes you pee.
It makes you feel like you pee your pants. It makes you feel like shite too. It doesn't really feel great because you're like don't have control of your body. So you may feel like flush, making a bad taste in your mouth. So those people are like, I'm allergic to this. Like I can't have it. And I'm like, well, you may have some internal bleeding with some of your visceral organs. So we're gonna go ahead and do this anyways. Just pre-dose them with medication. No harm, no foul. If you can wait. If not, strap them in and go for a ride. Conscious sedation, right? And some Dilaudid Versed and go for it. Don't do that too. All right, some guidelines, right? So check your GFR, greater than 60, kidney disease, family history, kidney failure. So all this good stuff. This is from the nephrology, urology geeks over there. So MRI, magnetic resonance imaging. How does this work? No radiation, better for brain, spinal cord, soft tissue. Detects your strokes, hemorrhage earlier than CT. Well, why if it's earlier CT than that, why don't I just send everybody to the damn MRI machine?
Expensive.
It's more expensive, it's less abundant, and it takes way longer. That's why we get our CT non-con first, is because it's faster, and it's going to rule out. When we talk stroke, we'll talk about this ischemic stroke window of thrombolytics. We need to know now whether they're having an active brain bleed before I push thrombolytics. Because if I do that and they're bleeding, what have I just done?
You're gonna bleed more.
I DC'd to JC, right? So they're dead. That's why we get that CT con or non-con first, okay? How does an MRI work? What have you guys been taught?
Magnets.
Magnets? What else? Magic? Any prior text in here, rad text or anything? Someone explain it. Magnets how? You guys ever wonder this stuff? Has anybody ever looked it up?
These things out of resonance and then as it falls back down, it creates a picture.
Yeah, so magnets, so and you guys should fact check this because I'm just going to make something up. It spins, this is getting back to your biochemistry. It's either proton, neutron, or electron. Y'all need to look that up. It spins it one way really fast, and then the magnet shifts it really quick and gets a picture. You guys are T1, T2 weighted. Does any of this sound familiar to you guys? Well, I'm not teaching it to you guys. I'm the last person to teach you. So what is akin to an MRI? You guys ever heard to like looking underwater, like without goggles on, is like a good. So is MRI the end all, know all? No, it's like it's one of, if not the best test we have in 2026. But you're still not going to see everything, right? So you're still not going to get everything. What's the best diagnostic approach for like soft tissue pathology? This is an ortho thing. It'd kill me if I say this wrong.
Open it up.
Go and look.
Yeah,
Right?
open.
Arthroscope, right? Open that sucker up and go and look, right? So, anyways, way off. All right, but I'll tell you with me, so my MRI where I see it is if I have a stroke alert and I get a CT non-con, CTA, I look at the head and neck, all the vessels are good, I will admit them for an MRI, MRA, and they'll get it done tomorrow. It's going to be more sensitive and specific for soft tissue. It's going to show strokes, ischemic strokes better too. It's also going to show these lacunar infarcts, which are your penetrating infarcts, a lot better than your CT. So we'll talk about it later. But I'm ordering them. I'm just never really getting them back and seeing what they say. So, okay. If they got metal, we send them to an MRI machine? No. Do not feel bad. Like if you overlook this and you're like, yeah, I ordered this for, like the protocol is going to catch it. Like radiology department isn't going to be like, hey man, like I put them through and their pacemaker ripped through their chest. Like they usually ask them to fill out a screening form. But for your SA, generally speaking, if they have metal in their body, let's screen that as well and know that that's not a good idea. Did you guys see the guy with the big chain in the MRI machine? What happened to him? He got decapitated. Does anybody not know this story? No. I don't know who it was, but it was in the news. Do you know? I guess I'm asking for this if I'm asking. So the guy with the chain I saw in the news, the guy with the butt plug, I'm not sure of. I'm going to leave that one alone. But the guy in the chain ran into an MRI, I think to help his wife, who was claustrophobic in the MRI machine. So he ran into the MRI, and it sucked him in and took his head off. He had like a big, like, really nice chain, Flavor Flav chain. It took his head right off, man. Killed him. So stay away from that stuff. No metal. And if you're getting an MRI, which most of you probably have had or will have in your future, make sure you don't have any metal on you. Like, what about my ring? Should I wear this? No, you shouldn't. Tell them. Let them know. So. All right, GFR, glomerular filtration rates. We want to make sure their GFR is okay. So this goes back to the same thing with contrast we just talked about. MRA, so we're doing angiography now. So now we're getting a load of dye into their vessels and taking a look at it, right? Looking for any aneurysms, any hemorrhages, any arterial venous malformations, or any other abnormalities that could show up. So this is your intracranial MRA, so showing the head on the left for you guys. On the right is the neck. Why do I care about the neck with my stroke patients? Clot, thrombi, embolism, right? That's probably a good indicator. Or a risk, like, hey, your neck looks like it's 90% occluded. Every time I turn my head to the left, I get dizzy and pass out, right? Well, your vertebral artery is 90% occluded, so that could be a problem. Or you guys, you heard of like people going to chiropractors and get like vertebral, that's not funny, I don't know why I laugh, like vertebral artery dissection, cracking their necks. Nobody's ever heard of that, just me. I'm going to dark web reading this stuff. So yeah, it happens. But this would be an excellent way to see it. I'd probably throw them on an MRI first, wonder why they're dying, or a ultrasound first, wonder why they're dying. PET scan. What's a PET scan? Don't tell me positron emission. What does it do? Cancer? Is that what you said?
Cancer.
Gives you cancer?
No. Shows.
Yeah. So we're going to tag our cells with a small amount of what?
Radioactive.
Radioactive material, as well as, yes, sugar. Did you guys talk about it? Glucose. It's not like table sugar where you just dump in like brown sugar, right? So fluoroxy glucose or sugar. So you basically tag a glucose molecule with some radioactive material. What are we looking for? What type of tissue likes sugar? What type of tissue use C6H12O6 guys? Glucose. Am I the only one that loves this stuff? Right? Like, what type of cells use glucose? Like bump them all, right? Like every single one, right? So if I'm tagging these cells, let's just look at the brain, and I'm looking for uptake, what am I looking for? Areas that maybe don't have uptake, atrophy, or what about areas that have excessive uptake? We don't want to take a swing at that one. What'd you say? Cancer. Why cancer? Cancer sucks, and it's just hyperproliferation of abnormal cells, and they just love to eat and create problems and grow, right? So I may see a tumor, just be a good thing for cancer. You guys are right. I could see atrophy. I could see low uptake, which would be concerning for dementia, or I could see high uptake when I'd probably see a positive tumor sign as well. So good. Biologically, we're not doing this. Interventional radiology is going to do this, but if you guys do an LP, they may inject some dye to see. Maybe they have an epidural abscess, arterial venous malformation, cord compression, or tumors. So it kind of makes sense, right? So we can do fluoroscopy, send some dye up there, and take a look at how patent it is. Bedside, but typically that's going to be interventional radiologists doing this. So. Contraindications of this, tumor or infection, like no kidding, if there's a nasty cellulitis, don't inject into it. Why? Because now I just introduced it into epidural space, right? So you didn't have meningitis, but congratulations, I got it for you. Bleeding disorders, use of anticoags, I would say if you need to reverse it, do all that. You can give them platelets or FFP. Elevated ICP, same thing we talked about for not tapping somebody before, getting some imaging. Okay, and then a carotid ultrasound, bedside. So if you're worried about someone's blood flow in their neck, who should get a carotid ultrasound? Everybody, right? So it's pretty easy. You guys, I would challenge you all moving forward in your career. Be familiar with and or take a class on ultrasound, and or if you get to your unit and you have an ultrasound, just take it out and train on it. Be like, I don't know, like this thing looks cool. We should do fast exams or e-fast exams, or check out your neck and see if I can see vascular flow through. Day one, guys.
Day one in the books.
Day one's down. What do you guys got? Any questions? We're gonna run it back tomorrow at 1.